Calcium is an important electrolyte in the body that is responsible for bone health, nerve transmission, muscle contraction, and enzymatic functions. When the body senses low serum calcium, the parathyroid gland releases parathyroid hormone, which then stimulates release of calcium from bones, enhances calcium reabsorption in the kidneys, and increases calcium absorption in the intestine to increase serum calcium level. Calcium level above 10.5 mg per deciliter is considered as hypercalcemia. Calcium level above 14.0 mg per deciliter is considered as severe hypercalcemia or hypercalcemic crisis. It is a medical emergency. An individual with hypercalcemia may present with confusion, headache, nausea, vomiting, abdominal pain, constipation, loss of appetite, kidney stones, frequent urination, bone pain, and muscle weakness or muscle pain. Delayed diagnosis and treatment could result in renal impairment, pancreatitis, severe bradycardia, heart block, and coma. Initial management of hypercalcemia typically begins with measuring serum parathyroid hormone level and serum ionized calcium level, as well as administration of isotonic fluid to achieve adequate hydration. Medications associated with increased serum calcium levels such as calcium carbonate, excessive intake of vitamin D supplement, thiazide diuretic such as hydrochlorothiazide, lithium, and teriparatide should be discontinued. If serum calcium remains high with elevated parathyroid hormone level, the patient likely has primary hyperparathyroidism. Primary hyperparathyroidism is the most common cause of hypercalcemia. It is due to benign parathyroid adenoma which releases excessive amounts of parathyroid hormone. Resection of parathyroid gland is the definitive treatment for severe hyperparathyroidism. A high 24-hour urinary calcium level supports diagnosis of primary hyperparathyroidism, while a low 24-hour urinary calcium excretion suggests familial hypocalciuric hypercalcemia. If the parathyroid hormone level is low or low normal, the appropriate next step is to measure parathyroid hormone-related peptide 1,25-dihydroxyvitamin D, also known as calcitriol, and 25-hydroxyvitamin D, also known as calcidiol. Of note, it might take several days for results to be available. If suspicion for malignancy is high, necessary workup such as CT scan of the chest, abdomen, and pelvis can be performed to evaluate for possible malignancy. Elevated serum parathyroid hormone-related peptide indicates malignancy-associated hypercalcemia, also known as humoral hypercalcemia of malignancy or paraneoplastic hypercalcemia, a condition characterized by production of parathyroid hormone-related peptide by cancer cells or direct release of calcium by cancer cells. This can be due to conditions such as multiple myeloma, breast cancer, lung cancer, renal cancers, and cholangiocarcinoma. Elevated 1,25-dihydroxyvitamin D or calcitriol level suggests ectopic production of 125-hydroxyvitamin D closed by conversion of vitamin D to inactive form by activated macrophages, causing increased calcium absorption in conditions such as sarcoidosis, tuberculosis, fungal infections, and lymphomas. Granulomatous diseases typically respond to steroid therapy. Elevated 25-hydroxyvitamin D level suggests excessive dietary intake of calcium or vitamin D. If serum parathyroid hormone-related peptide 125-dihydroxyvitamin D and 25-hydroxyvitamin D are not elevated, the hypocalcemia could be secondary to bone metastases or multiple myeloma or vitamin A toxicity or hyperthyroidism. A high alkaline phosphatase level and a normal gamma-glutamyl transferase level suggest bone metastasis or mineral bone disease from immobilization. Serum protein electrophoresis, urine protein electrophoresis, and serum free light chain assay should be performed if multiple myeloma is suspected. A single dose of biphosphonate such as intravenous zoledronic acid should be administered for patient with malignancy-associated hypercalcemia. Zoledronic acid should be avoided in patients with severe renal insufficiency. Severe hypercalcemia of malignancy can also be treated with denosumab as a first-line agent. Calcitonin can be administered for 1 to 2 days to quickly lower calcium level. Calcitonin can become ineffective after 48 hours due to tolerance. This is known as tachyphylaxis.